Thank you very much, Stephen, for the introduction, and thank you, everyone, for coming out. It's really very gratifying to see so many people interested and willing to spend a Saturday morning and many days for many people here talking about and thinking about and learning to practice better nutrition. We certainly need you. I think this cartoon, and I don't know who did it, but they did a great job. I almost could stop my talk right here. This is Dancer talking to Prancer and about all the cookies that would eventually keep up with poor Santa. And in some ways, that does describe where we are. I've been told it's good to start and end a talk with a positive message. So here's my positive message to begin with. And it is pretty, in fact, I think remarkably impressive that the enactment of new standards for food quality in schools had a very major impact on diet quality of foods available for kids in schools. In just a few years, on a scale of 100, it went from about 58 to about 81. And that's a huge change. It doesn't mean that all the kids ate all the healthy foods, but what's available to them is a first step, and that's been a huge step forward. Unfortunately, the not so good news is that those standards are being rolled back right during this month by the current administration. And in between the good news on the beginning and the end, there's a big sandwich of not so good news, unfortunately. As I mentioned that last night very briefly, rates of cardiovascular disease, coronary heart disease in particular, had been coming down since the early 1960s. In fact, a huge decrease, about 80% decrease in age-specific cardiovascular and coronary heart disease mortality. But among people now in younger generations, under age 65, that decline has stopped, and it's actually starting to creep back up again. And that's a huge problem because that is the #1 death still in the United States and worldwide. And while it looks like cancer rates overall are continuing to come down, again, the picture is very different if we look by birth cohort, in other words, by generation. And there are half a dozen obesity-related cancers, like colorectal cancer, that, again, had been coming down for decades, and now they're on their way back up. And unfortunately, this very strongly predicts is that those younger generations go through their life cycle, they will carry with them the higher rates of these obesity-related cancers. And we can't say for sure all the factors that are driving this, but almost certainly it is the fact that these are the generations that became obese as children, and now they're moving into the middle age and experiencing the inevitable consequences of that extra weight that they are carrying with them. And all of that is actually resulting in decline in life expectancy in the United States. For 3 years in a row, we've had a decline in life expectancy. Certainly the opioid epidemic has accelerated that decline in life expectancy, but the biggest underlying factor is, again, the obesity epidemic. And this decline in life expectancy is something we haven't seen in this country. It's been continued increases. But it's not inevitable, and if you see in this figure, thanks to the economists, Japan has just continually improved their life expectancy, and now there's a 6-year gap between the United States and Japan in life expectancy. That's enormous. You would think this would be setting off alarms in medical schools, in NIH, and Health and Human Services in Washington, but it's not. There's very little attention being paid to this decline in life expectancy. Again, some attention to opioids, but very little attention to the underlying problem of the obesity epidemic now having impacts on many, many diseases and life expectancy. On the planetary health side, the situation perhaps looks even more extreme. And you don't need fancy statistical models to realize that there are huge and unprecedented changes going on, that the Arctic Ocean is opening up in the summertime, and it hadn't until just a few years ago. Glaciers all around the world are retreating, and that's a really good indicator of long-term trends, not just month to month and year to year. I spent 3 years working in Tanzania, and there was always a healthy snow and ice cap on top of Tanzania, on top of Kilimanjaro. And now it's just a little wisp, and predictions are that that's going to be gone in just about 10 years. And most disturbingly, the Greenland ice cap is melting. What we've entered are a number of vicious circles, and that's what's really most worrisome here, that this is not just a linear process, it's an accelerating process. There's global temperatures increase that melts the permafrost in the northern areas, that releases more methane. The snow cover retreats, so the sunlight is not reflected back in the same way. Again, the Arctic ice cap is melting. That releases methane, and that's been stored at the bottom, and also there's less reflection of sunlight back, and people turn up their air conditioners, and all those things create more climate change, temperature increases, and this becomes an accelerating vicious circle, or some people have called a tipping point. And that's what's really worrisome. Again, this is not linear. The New York Times made this very nice figure a couple of years ago, and you can see back as far as in the 1800s when we started recording temperatures, there was some bumps up and down, and then it looked like a slow increase, and now an accelerating increase upwards. And as you can see at the very far right of that, these are the hottest months recorded. And just even this past month, we had many in places hottest months. These are global temperatures. Many places hottest months. Last month it was 74 degrees in Boston 2 days in January. That's just completely unprecedented. And this past year was the second hottest year in recorded history. I think the previous hottest year was just 2 years ago. So we're year by year, all the years are among the hottest 10 years. So this acceleration is what's really worrisome. And there was just a report of a couple of months ago about the acceleration in the Greenland ice cap melting. And it's now melting at a rate 7 times faster than it was in the 1980s. So we all knew that climate change was happening back in the 1980s, but this acceleration is something that I think no one really anticipated. And this has huge consequences for producing food and just for simple human survival. These are some maps that the Union of Concerned Scientists put together. And you can see there were, at the bottom there, a few places in the very southern part of the US where we had 50 days a year with temperatures over 100 degrees. That's pretty hot for 50 days. But even by mid-century, there are now those places and many more are going to have 100 days per year of temperatures of 100 degrees or greater, and many big part of the country now having 50 days a year with temperatures over 100. And by 2100, not that far away, our grandkids will be there, that big swaths of the country will be having 50 days a year or more with temperatures over 100 degrees. And that has direct consequences. People die in those kinds of temperatures. You can't produce foods in many of those big areas with that kind of temperature change. So this is, and of course there are many other changes. Sea level rises, wildfires that are consequences now that can be directly linked to this very dire situation of accelerating climate change. I could go on, but I'm going to talk mostly about food and health. And that story, of course, goes way back to Hippocrates and things that were recognized just by clinical intuition a long time ago. But the modern era of data science and studies of diet and health really, I think, started with this very famous study, the 7 countries study by Ansel Keys, that was looking at 14 different populations of about 1,000 men each in 7 countries. And probably the most important finding that they had was essentially that rates of heart disease differed about tenfold among the various countries. And that had really not been well documented before by standardized methods. And the obvious question is, why do these rates differ so much among countries? There's a lot of interest in genetics now, but some relatively simple studies showed definitively that these differences were not due to genetic factors, because people who lived in low incidence areas, like at the lower left, that's Japan, a couple of villages there, but Crete actually had the lowest rates of heart disease. And when those populations moved to the United States, they fairly quickly developed the same rates as the European Americans living in the United States. So that says that very definitively that these huge differences were not due to genetic factors. So what is it about the non-genetic factors, which we broadly call environmental factors? And there were some clues from the 7-country study that diet might be important, because there was this very strong correlation with saturated fat. But Keyes knew that there were lots of other factors involved, and this didn't prove that saturated fat was the cause of heart disease. He also looked at total fat, and actually that was not related to coronary heart disease, because Crete actually had the same, about 40% of calories from fat as did the highest risk country, as Finland. But the type of fat, of course, was totally different, that it was dairy fat primarily in Finland and olive oil primarily in Greece. So that was an early clue that fat per se was not the problem, although it hinted that saturated fat might be the problem. But this certainly was a great stimulus to more research on this topic, and I'll come back to some of that. The same picture was seen for many cancers. This is looking at breast cancer rates around the world back in the 1950s and the 1960s. And again, very strong correlation with either total fat or animal fat in the diet. And again, the migrants from Japan down in the lower left there and other low-risk countries who came to the United States, actually it took them about 2 generations, but they caught up with the rates of breast cancer of European Americans living in the United States. So again, these huge differences are not due to genetic factors, something about diet and lifestyle. And there were some clues that it might be fat in the diet, or animal fat more specifically. But there was certainly the need to do more detailed studies. However, this slide was shown over and over again, and it became repeated so much that there was a general conventional wisdom that fat in the diet was the major cause of heart disease and many cancers, breast cancer included. So that conventional wisdom was reflected in this 1992 food guide pyramid. Probably those of you in my generation remember 1992. This was a big deal. A food pyramid comes out, and the message is very clear that up at the top you avoid all fat-containing foods, including meat, butter, but even oils. Every bit of fat should be out of the diet as much as possible. And therefore, if you don't eat fat, you've got to eat something. And so that means you're inevitably going to eat large amounts of carbohydrates. So even though there was never any evidence that eating a lot of carbohydrate was really good for you, we were told to have up to 11 servings of things like potatoes and Wonder Bread and Rice Krispies and bagels, as if that made no problem. And then they put potatoes there in the vegetable group. You could have up to 13 servings of starchy foods per day. That was said to be what was good for us. But there were some red flags that became apparent to me and some others in the late 1980s that this might not be right. This was what we can call a controlled feeding study, where you take just a few dozen volunteers and you almost lock them up and you give them different diets, and so you're controlling what they ate. And we can see this is a study comparing olive oil with a low-fat, high-carbohydrate diet. And on both diets, total cholesterol comes down pretty equally, actually a little bit more on the olive oil diet, if anything. But what happens on the high-carbohydrate, low-fat diet, that HDL cholesterol, the good cholesterol, goes down and triglycerides go up. And we know that those changes predict more heart disease, not less heart disease. So one would suspect on the basis of this evidence that you'd be better off having the olive oil diet rather than the lower fat, higher carbohydrate diet. And in fact, many other studies have followed up. This has been reproduced many times, and it doesn't matter what type of plant oil, whether it can be soybean oil, canola oil, you get basically the same kind of response as you do with olive oil in this kind of diet, this kind of dietary comparison. But we know that there are many pathways, many other pathways that could link diet with coronary heart disease over on the right. What I've talked about so far has just been pathways operating through blood lipids, blood cholesterol and triglycerides. But diet can also act by influencing blood pressure, by looking at thrombotic tendency, the tendency to form clots in your arteries, insulin resistance, and oxidative stress, homocysteine levels in your blood, by affecting inflammation, and also by influencing ventricular irritability and arrhythmias. And that's really important because arrhythmias are how most people die of heart disease. So we can't confidently predict the effect of diet on heart disease just by looking at the effect on blood lipids. We also would like to look directly at how diet is related to heart disease and other outcomes as well, because that integrates the effects operating through all of these different pathways. And there are likely some other pathways. This is not meant to be exclusive. There's recent evidence that there's a substance called TMAO in the blood that's a result of the metabolism of certain dietary constituents in the gut. So there's ongoing research, probably more pathways even than this. But the point is we'd like to look directly at diet and heart disease. So in principle, in theory, the best way to do it is by doing a large randomized trial. By, for example, if we're looking at, say, total fat in the diet and coronary heart disease, we'd randomize many thousands of people into high fat or low fat and follow them for years to see who developed more heart disease. The problem is that we can randomize people to low fat or high fat, but they don't always stay on those diets. People are people. They're not animals in a cage where you really can control the diets. And the reality has been that most of those studies have not been very successful. And I'll circle back to that briefly. That the next best kind of study would usually be what we call prospective cohort studies. And this is the kind of study that my colleagues and I have been conducting for the last 40 years. The first was the Nurses' Health Study that enrolled about 121,000 nurses in 1976, initially to look mostly at oral contraceptives and breast cancer, but I realized this would be a great opportunity to look at diet. So after a series of pilot studies, we first started collecting dietary data in 1980. And several members of the Nurses' Health Study are here, I understand. And it's really important to point out the participants have been remarkable, that after over 40 years, there's still been about 90% participating here. And this work would not have been possible without the commitment and dedication of the participants. So in this kind of study, we collect dietary data by an extensive dietary questionnaire. You can ask anybody who's been in the study. This is quite a bit of work to fill it out, but we've documented with lots of detailed studies. It does provide highly valid data about what people eat. And we also collect data about smoking, physical activity, you name it, we have it in our computers. And so when we want to look at, say, total fat intake and heart disease, we can adjust statistically for differences in smoking, physical activity, and other variables. And we enrolled about 52,000 men in 1986 and another 116,000 nurses in 1989, specifically to look at earlier life diets and exposures, because there's a lot of evidence that what we eat and what we do early on has a bigger impact on breast cancer than what we do in midlife and later. And at the bottom, I've listed some of my colleagues here who have contributed. This is a very team-oriented, or team-based, multidisciplinary study of experts in many different areas, and there are many more people who have contributed over the years to these studies. So this is what we saw in a recent analysis looking at total mortality that we published just a couple of years ago, and I could show almost the same figure for looking at coronary heart disease that we published in 1997. But by this time, when we put these big populations together and started off only with the healthiest people, that it included about 130,000 men and women, now with up to over 30 years of follow-up and many repeated measures of diet. About 30,000 participants had died during that period of time. So unfortunate, they were aging. I mean, the nurses, particularly in the early study, but that gives a great statistical power to look in detail at types of fat and other aspects of diet. And so what we're doing here, we're showing increases in risk of death for the same number of calories from different types of fat versus the same number of calories from carbohydrate intake. And that blue line at the top is trans fat, and you're probably familiar with that. That is by far the worst type of fat, gram for gram, compared to any other type of fat. And fortunately, based on our earlier data in trans fat and some short-term studies, trans fat is out of the diet now. It's illegal after June of 2018 to produce trans fat. And then the orange line is saturated fat. And you can see there is some, it's not a strong positive association, but there is an increased risk of death for saturated fat compared to overall carbohydrate intake. And the yellow line is monounsaturated fat, actually related to lower risk of total death and coronary heart disease. And then the purple line is polyunsaturated fat in the diet, strongly related to lower risk of mortality. So if you look at all fats combined, the good fats and bad fats sort of balance out. Although for total fat, now we actually do see that higher fat intake is related to lower mortality. And that's because we've gotten rid of trans fat in recent years. So the type of fat in the food supply has actually gotten better, quite a bit better, over the last 15 or 20 years. So, but really total fat is not the important variable. The type of fat is what's really by far the most important. And so getting trans fat out of the picture, emphasizing replacing foods high in saturated fat with foods higher in unsaturated fats, particularly polyunsaturated fat, is a direction to go based on this kind of evidence, which fits very perfectly with what we see in short-term controlled feeding studies looking at blood lipids. There was one successful randomized trial to look at a related question, and this is the Predimed study. And this is a fairly unique study because they did have biomarker data to show that people really did stay on the diets to a high degree during the 5 years that the study went. And the study was stopped at about 5 years because the results were statistically significant, and the monitoring committee viewed it was unethical to continue on in the study. The basic study was 3 groups. Control group, which was advised to go on low fat, to reduce fat intake, although they only modestly reduced their fat intake. And then Mediterranean diet with added nuts, or Mediterranean diet with added extra virgin olive oil. And both of those forms of the Mediterranean diet were beneficial, about a 20 to 25% reduction in risk of cardiovascular disease. Both of those statistically significant. Again, fitting very much what we see from the short-term studies looking at changes in blood cholesterol fractions. But then, this is why people are confused. This is Eat Butter, cover of Time magazine, based on a study that was mentioned yesterday, deeply flawed in many ways. But one of the key issues still is the comparison. What are you comparing butter to? If you're comparing it to a high trans fat margarine, that margarine may actually be worse, but you get a different picture with different comparisons. So we did where we have this very large set of 3 populations, we did actually look at replacing the dairy fat with different sources of calories, different types of fat and different types of carbohydrates. And so the vertical line there is the risk for butter. To the left is lower risk with the replacement factor, like on the top line, that's vegetable fat replacing butter, highly significantly lower risk of both heart disease and total mortality. We saw very similar results looking at either of those. This is looking at total cardiovascular disease in this figure. And replacing the second line there, looking at replacement of butter with other animal fats, like from beef, there actually was some increase in risk of total cardiovascular disease. But basically everything else, the replacement factor was better than dairy fat, basically butter. So that included polyunsaturated fats, both omega-6 and omega-3 polyunsaturated fats, and with whole grains, calorie for calorie at the next to the bottom line, lower risk. But replacing butter, calories from butter with calories from refined grains, it was about a wash. There was very little difference. So again, butter, the effect of butter depends on what the replacement is. If you're replacing it with beef tallow, actually the butter may look a little bit better, but if you're replacing it with refined starches, there's not much difference, but all the healthy oils are replacing butter, lower risk of cardiovascular disease. And I would mention in all these analyses, we have adjusted for smoking and activity and other risk factors. So again, the comparison to emphasize is really the issue here. This is if you're looking at saturated fat in the middle, replace it with trans fat up at the top, higher risk of heart disease. Replace it with carbohydrates. On average, not much difference, but it depends on the carbohydrate too. If you replace it with refined starch and sugar, likely to be higher risk of heart disease. But if you replace saturated fat with some whole grains, that will reduce risk. But most importantly, replacing saturated fat with unsaturated plant oils is related to lower risk. And that includes olive oil, which has been most studied, but almost surely canola oil, which has been studied as well, and other types of non-hydrogenated plant oils. So just to summarize on fat and coronary heart disease, coronary heart disease rates can be dramatically reduced by nutritional means, but this will not be achieved by replacing saturated fat with carbohydrates in general. And we should abandon recommendations regarding percentage of energy from fat and avoid pejorative references to fat or fatty foods. Fat per se is not bad. And advice about dietary fat should focus on replacing saturated fat and getting trans fat out of the diet, but replacing saturated fats with vegetable oils, including sources of omega-3 fatty acids. I didn't have time to talk about those, but also omega-6s. They're both good, and most of what I showed you was omega-6 fatty acids. And red meat should be replaced with nuts, a combination of nuts, fish, poultry, and legumes, and there's a lot of flexibility about that I'll come back to. Of course, again, one of the major motivations for the emphasis to replace fat with carbohydrates was the idea that that would reduce breast cancer risk. And this was looked at in a very large randomized trial, the biggest, most expensive randomized trial ever done, the Women's Health Initiative. Was anybody here in the Women's Health Initiative? Not obviously to me up here anyway that I can see, but this was, 48,000 women were randomized, and they're basically, this is looking at the cumulative incidence of breast cancer, and there was no statistically significant difference. Now, one might say that really proved that reduction in fat does not influence breast cancer risk, but the reality was, when you looked at the biomarkers that are sensitive to fat intake, there was no difference at any time during the follow-up, which really means that there was almost no difference in fat intake between these two groups, that people really didn't follow their diets. Now, another limitation of the Women's Health Initiative was that it went on for an average of 7 years, and that may be short in terms of effects of diet on cancer risk. So we've looked at this in our population of nurses who we followed much longer, and up to 20, even now 30 years of follow-up, we don't see that there's a lower risk of breast cancer with lower fat intake. It's just flat. But, so if fat is overall is not the villain, that doesn't mean that, okay, therefore you should load up on red meat and butter. And a lot of people in the sort of paleo-related movement have made that leap, which defies logic. That just because fat doesn't give you breast cancer or heart disease or make you fat doesn't mean that it's good for you. And so we've looked at that in a lot of detail. So how do we look at that? A beginning is just to look at what is in different foods. If you're looking at, say, different protein choices. And we know from many studies done over, again, going back 50 and 60 years, that if we increase polyunsaturated fats, that reduces LDL and total cholesterol. If we increase saturated fats, that increases LDL cholesterol and total cholesterol. So that ratio, polyunsaturated fat to saturated fat, is widely used as a predictor of of heart disease risk, changes in serum cholesterol and heart disease risk, presumably. So this is just looking at the PS ratio in different major protein sources. And beef has very little polyunsaturated in it and quite a bit of saturated fat in it. So the PS ratio is very low. Chicken and poultry is actually a lot better, a much higher PS ratio than beef does, salmon even more. But if you really want to go to high PS ratios, it's from the plant protein sources. So the next step would be to say, let's not just look at what's in the foods, let's actually take these foods and do these controlled feedings, the lock them up studies, where you lock up a few dozen people. It used to be we could get our graduate students, but they don't legally or ethically allow that anymore, so we have to go elsewhere. I was in those studies. I got locked up. This is a meta-analysis summary of the different controlled feeding studies, randomized studies looking at the effects of different protein sources on LDL cholesterol. It's really a well-established risk factor for heart disease. And on the right side, over here, start with from the right, if this is looking at red meat versus usual diet, and there's no statistically significant difference. And that's not too surprising because in this kind of study, what is usual diet? It's pretty horrible that less than 5% of Americans actually meet the dietary guidelines. And those dietary guidelines are sort of low bars, not necessarily optimal. So that would be saying that red meat is just as bad, it's just as good or bad as the usual diet, and we know that usual diet is not very good. Then the middle bar there is looking at red meat versus other animal protein sources, and not really a significant difference. And then, but on the left side there, that's looking at red meat versus plant-based protein sources, nuts, legumes, soy products. And there clearly is an elevation in LDL cholesterol with red meat versus those plant protein sources. So given that alone, you would have a strong a priori expectation that eating red meat would be related to higher risk of coronary heart disease. So we've looked at that in the Nurses' Health Study. That this is where these data are coming from, adjusted for smoking and everything else. And that's basically what we see. Although we do see that poultry, if the vertical line is the risk for red meat, to the left of it is lower risk with a replacement food. So poultry, fish, nuts, beans are all associated with lower risk of coronary heart disease, replacing serving per serving red meat. But the lowest risk were with nuts and beans. But consistent with the PS ratio, poultry and fish actually do look better than red meat. And we've then gone on to look at other endpoints, diabetes risk, stroke, coronary heart disease, and total mortality. And for all these endpoints, we see the same picture, that replacing red meat, bar to the left of the line, with any of these other foods is related to lower risk of coronary heart disease. But nuts actually seems to be the food that is most consistently and is most strongly related to lower risk of coronary heart disease. For breast cancer, during midlife, we really don't see that same, we don't see much going on there, interestingly enough. But this is looking at diet during high school years that we've collected. This is data from the Nurses' Health Study 2. And we've done some validation comparing what our participants said with what their mothers said, and there's actually a pretty reasonable correlation. So it seems to be pretty good information. Again, the vertical line is red meat. So replacing serving per serving legumes for red meat, lower risk of breast cancer. Nuts, same trend, not quite statistically significant. Poultry, inverse risk. Now, of course, we're not going to tell anybody they should eat all legumes or all nuts. That we want to look at the whole dietary pattern. And that dietary pattern does describe pretty much the Mediterranean diet, the bottom line there, which is the total of legumes, nuts, and poultry. If you combine those as a package, highly significantly lower risk of breast cancer. And I should say this is breast cancer during the premenopausal years. These women have been pretty young, were pretty young at the time of this analysis. But there's then the next step. In general, as I've shown the epidemiologic data, and I've shown you our own data, other studies have been very consistent with the pattern I've described. Then the question is, well, how much red meat? Does it mean we have to totally eliminate it? Or is there room for some red meat? There are a lot of recommendations which say, you know, X number of servings per week or 50 grams per day. The question is, and we face this question all the time, whether it's ionizing radiation or doses of environmental carcinogens, very often we can't say it's not practical to get to zero, so we set some standard and want to keep people below that level. But it's hard when we have a basically pretty much linear continuous relationship here. This is looking at red meat and total mortality in men on the left, women on the right. And it's basically almost a straight line. Now, you would reasonably logically say that the lowest risk would be zero intake of red meat. But it's possible when you get down to very low levels, like we do anything, the data get fuzzier, and it's hard to distinguish zero red meat from a small amount of red meat in the diet. So we were, in this project, the Eat Lancet project, we were charged with coming up with some dietary targets that would be healthy and sustainable. So we, looking at red meat, these are the kind of data that we looked at. This is looking at red meat and risk of type 2 diabetes, where the studies are very consistent, showing positive associations. And even between the lowest and the next to the lowest quintile of red meat, there is a small but significant increase in risk of type 2 diabetes. So that amounts to about, that increment amounts to about 2 servings a week. So we set as a target 1 serving a week. With that range of 0 to 2 servings a week is the range. But we can be pretty confident that at 1 serving a week, there'll be, if anything, only a small increased risk of type 2 diabetes. But again, if you wanted to, you could go to 0 red meat. Certainly no reason to not do that. We've also looked at this issue of plant-based diet with another very simple way in relation to diabetes, coronary heart disease, and total mortality. We get the same picture for all 3 of these outcomes. But we created what we call a plant-based dietary index, where it's very simple. You get 1 point for 1 serving a day of any plant food and a negative point for 1 serving a day of an animal-sourced food. And then you just add up the points. And so we can see this is the blue line, that the increasing score, plant-based diet score, lower risk of diabetes, heart disease, and total mortality. And so that's one point I wanted to make. It's not a sharp cutoff, that taking even modest steps in that direction can have important health benefits. But the other part of it is that not all plant-sourced foods are good foods. Like basically donuts and Coke are plant-based foods. But we would all agree that those are not healthy foods to be consuming. So we basically separated unhealthy plant-based foods from healthy plant-based foods. So we only got points for healthy plant-based foods and negative points for unhealthy plant-based foods. And so that red line is increasing unhealthy plant-based diet score. And that's actually the worst of all. So that just saying plant-based diet isn't enough. You can have extremely unhealthy diets that are plant-based. It's healthy plant-based diets that we want to go. And that's the green line at the bottom. That's where basically you've got more points for nuts, legumes, soy products, whole grains, fruits, and vegetables. And that gave the best overall risk looking at these plant-based diet scores. So to summarize, protein sources replacing red meat with a variety of other protein sources, especially nuts, soy, and other legumes, will have major benefits. I didn't go into it here. There is a lot of evidence that having fish in modest amounts, 1 or 2 servings a week, will reduce sudden cardiac death because of the high, almost for sure, because of the high amounts of omega-3 fatty acids. And if you're becoming a vegan, you do have to be very careful to make sure you do get enough omega-3 fatty acids. It's possible with plant sources, but you could easily miss out on those if you're not careful. And so when we look at long-term studies, pescatarians who have fish and otherwise plant-based diet actually have as good or maybe even a slightly better outcome in terms of cardiovascular mortality. Now, to go back to the planetary health, it's very clear that what we eat and our food choices have a major impact on greenhouse gas production and other environmental variables as well. But of all of these, the greenhouse gas issue is the most serious, and because we're going into vicious circles, it become irreversible. And if we look at greenhouse gas production, these different colored bars are looking at per serving or per calorie or per weight. No matter how you look at it, beef intake is by far, along with lamb intake, by far the biggest source of greenhouse gas. And over on the right are plant-based protein sources, and they have very low greenhouse gas. Now it looks like over on the right you see dairy there in the red, but that's because this analysis in the red there used per weight, which milk is 90% water. So that's, if you look at it per calorie or per gram of protein, dairy looks like cheese, which is over toward the left there. Not as bad as beef, but close to it. So looking at a lot of the literature looks at foods by weight, and when you put dairy into it and then look at milk, of course you get a very misleading kind of answer where nuts are almost zero water in them. So looking at something that's 90% water compared to nuts and dry beans doesn't make sense at all. But the bottom line is that legumes, soy, nuts have about somewhere, depending on the analysis, 1/20th of the greenhouse gas production compared to beef. And legumes are very similar. So it matters a lot, and I'll come back to that. The quality of grains also is, and quality of carbohydrate overall is extremely important. This is a slide thanks to General Mills, and this is what they do. They take healthy whole grains, and if they grind them up and turn them into flour, we have whole wheat flour, whole oat flour. It's whole wheat, but ground up into fine particles. But most of the wheat and grains in the foods that are fed to humans are refined grains. And that means they've taken off the bran on the outside, which is where most of the vitamins and minerals reside. And then they chip out the germ, and that's the embryonic plant. And that germ is coated in oil, healthy oils, to protect it from oxidation so it can sprout a year or two later under the right conditions. And so all the lipid-soluble vitamins are there in the germ. And then you're left with the endosperm, which is mostly just starch. And then they grind that up and create flour, which we make into Wonder Bread and bagels and things like that. Then there's all this germ and bran left. What do they do with that? Of course, they don't throw it away. That's where all the nutrition is. So we feed that to animals, and they grow big and strong. And we eat the stuff over on the right, the refined flour. So what does that do to us? We've looked at this in multiple ways, but one way is creating glycemic load, which reflects the glycemic index of the food, and it's very high in rapidly absorbed carbohydrates like white flour and potatoes. And it also, the glycemic load takes into account the amount of that food that we're eating. And so this is looking at risk of type 2 diabetes in the Nurses' Health Study. And in the back, going from right to left, we have increasing glycemic load, and going from back to front, we have increasing cereal fiber basically from whole grains. And so that combination of high glycemic load and low cereal fiber is related to about a 2.5-fold increase in risk of type 2 diabetes compared to women who had the low glycemic load and high cereal fiber intake. And sadly, those women in that back corner were very often women who were doing what they were being told by the food guide pyramid. Load up on Wonder Bread and bagels and that kind of stuff, and not even going down the road of all the junk food that's high in sugar. And so they were following those, what they thought were good guidelines, but ending up with higher risk of type 2 diabetes. Now, of course, another major source of carbohydrates are sugar-sweetened beverages. And those are, if you had to pick one food that is most unhealthy, probably it's going to be sugar-sweetened beverages because, again, you can have huge amounts of sugar, 16, 17 teaspoons per 20-ounce serving with a standard beverage, Coke or other soda. And the average consumption among younger American men, for example, or low-income Americans is about 3 servings a day. So this is not just 1 serving, but 3 a day. And that's huge. So this is looking at risk for 1 serving a day in the Nurses' Health Study 2, about an 80% higher risk with 1 serving a day or more of sugar-sweetened beverage. The orange bars are after we adjust for body mass index. So that just means that part of this increase in risk is explained by the weight gain we get from drinking more sugar-sweetened beverages. So to summarize, for carbohydrates, like dietary fat, carbohydrate quality rather than the percent of calories from carbohydrate appears to be important for health. And consuming grains in the form of high fiber whole grains will reduce risk of type 2 diabetes and coronary heart disease, but high intake of refined grains is likely to increase the risks of these diseases. And high intake of refined starch and sugar is particularly problematic with underlying insulin resistance. And I didn't actually go into that, but there are a lot of people who are predisposed to insulin resistance, either by being overweight or by having a genetic predisposition to risk of type 2 diabetes. And actually, what we see is, if we look around the world, a lot of the world's populations have a higher risk of type 2 diabetes related to more predisposition to insulin resistance and are more susceptible to these bad diets. So the good news is everybody can have a low risk if we follow a healthy diet, even if you are predisposed, even for genetic reasons, to have a higher risk given a bad traditional Western type industrial diet. And reduction of soda and other sugary beverages is a high priority. A few words about milk and dairy. The belief is, in the rationale for recommendations, current recommendations of 3 servings a day, is that it contains a lot of calcium and that's necessary to reduce fracture risk. But when we've looked at fracture risk as a function of milk consumption or overall dairy food consumption, this is what we see. It just really is flat. We don't see, even with almost 30 servings of dairy a week, we don't see a reduction in risk of fractures. And if we look at total calcium intake, we also don't see that high calcium intakes are important for reducing fracture risk. We definitely need some calcium, and our bones are made of it. There's many important functions of calcium. We have to get some, but it looks like we don't need to have this very high dairy consumption that's currently being recommended to have adequate calcium intake. And there are some potential negatives of high dairy consumption, and there's a lot of evidence now that high dairy consumption is related to higher risk of aggressive prostate cancer in men. This is a slide from many years ago from the Seventh-day Adventist study showing that men who had 3 servings a day of dairy had about almost a 2.5-fold increase in risk of fatal prostate cancer, and we have data that supports this as well. So overall, the literature does support higher risk of prostate cancer, especially aggressive prostate cancer with higher dairy consumption. Now, having said that, there's also some evidence that, in fact, strong evidence that dairy consumption does reduce colorectal cancer risk, and almost surely that is because of the calcium that's there, because we can see that there is some reduction with calcium supplements as well. So I think if someone is having no dairy consumption, you might want to consider a modest calcium supplement, 500 or 600. It usually comes in 600 milligram units, but you don't need to take 1,000 or more milligrams of calcium supplements in general, from what we see to get adequate calcium intake. This is looking at looking at a Mediterranean diet in relation to cognitive function. And dementia, decline in cognitive function, is, I think, a concern on the minds of almost anybody who's sort of past midlife, because we see our relatives who have been affected, and as physicians, we certainly see lots of people who we've who've had healthy lives, and partly because we've helped people live 10 years longer than people were living back in the 1960s. A large part of that through healthier lifestyles. This is certainly not a way any of us would want to depart, is spending years in a nursing home demented. And so in terms of absolute numbers, because of success in prolonging life, this is becoming a bigger and bigger problem. Although interestingly, if we look at age-adjusted data, in other words, if for a 70-year-old or an 80-year-old, the risk now is quite a bit lower than it was 30 or 40 years ago, but still the risk is way too high. So we'd like to find ways to reduce that risk, even if we can't prevent 100% of it, like we have done for heart disease. And there's a lot of evidence now, this is what we see in our own data, looking at Nurses' Health Study and decline in cognitive function, that there is a quite strong inverse relationship, lower risk of cognitive problems with higher Mediterranean diet score. And when we've dug down more deeply in the Mediterranean diet pattern, what's the most important factor, probably multiple aspects contributing, but the most important factor does seem to be vegetable and fruit intake. So this is looking at just higher vegetable intake alone. And now we're digging down, looking at type of vegetables. That seems to make some difference as well. So I think this is an active area of research, but compared to what we had even 5 years ago, there's a lot of evidence now that a healthy, largely plant-based diet and healthy plant-based diet, terms have been used like whole food, healthy plant-based diet, will have benefits for maintaining good cognitive function later in life. Now, overweight itself is obviously a huge issue, and the epidemic of obesity is unabated. We're up to about 40% obesity in the United States. The prediction is it'll be 50% by 2030 if we're projecting out the trends, and there's nothing to suggest that we're doing anything that is reversing those trends at this point in time. I think everyone knows that there's a strong relationship between obesity and risk of heart disease and total mortality. And it's not, I should also say, it's not just obesity. It's even modest overweight is related to those risks as well. So in the middle of that part there, where there's some increase, that's in the overweight, but not yet obese range. There's still increasing risk of cancer. And what is often neglected, given a lot of attention to childhood obesity, and the childhood obesity absolutely deserves every bit of attention and double and triple attention that we're giving it now. But what's relatively neglected is weight gain by adults. And I think that may be an easy out, it's been an easy out for a lot of adults. You know, it's not our problem, it's the kids, it's the kids. No, as adults, it's our problem. Actually, the biggest contribution to obesity comes from weight gain after age 20 by adults. And this is looking at weight gain after age 18 in women or after age 20 in men in relation to a composite outcome of diabetes, heart disease, various cancers, and total mortality. And as you can see, just even modest, from those error bars in the middle, even quite modest amounts of weight gain that considered almost normal are related to increased risks of many adverse health outcomes. And of course, the risk goes up with more weight gain. And is that weight gain inevitable? No. Going back to Japan, it is amazing looking at the data coming out from Japan that the body mass index has not increased over the last 40 or 50 years in Japanese women. And they're still at 5% or a little bit less in terms of the prevalence of obesity compared to 40% in the United States. So we talked a little bit about that last night. We aren't sure exactly why, but a lot of it is mindfulness and attention to what we're eating, emphasizing quality over quantity of food, and not eating until we're stuffed, eating until we're approaching fullness, not till we're needing to loosen our belt and stagger away from the table, which is sort of a norm in American culture. So is it fat in the diet? For a long time, there was a conventional belief, again, that fat in the diet was the major factor contributing to obesity and weight gain. But the evidence is quite clear that that is not the primary issue. In fact, this is a meta-analysis Dr. Tobias published from our group just a couple of years ago. There are now, we could identify 52 randomized trials that had lasted for 1 year or longer of fat reduction. And it is important that trials last at least 1 year because people lose weight on almost any new diet. Part of it is just change and paying attention to what we're eating. But most of those new diets, after a few months, that reverses and people start to regain their weight again. So a minimum, studies need to be a minimum of a year long. And to the right of that line in the middle, that's favoring higher fat, and to the left is favoring lower fat. So you can see actually on these randomized studies, on average, people did a little bit better on higher fat diets rather than on lower fat diets. But the difference was fairly small, and essentially that overall I think the fair conclusion is that the percentage of calories from fat does not make very much difference. But if anything, it was favoring lower carbohydrate diets. This is a really good study published after that meta-analysis was done. This is by Chris Gardner at Stanford. And it was big, about 800 participants. And the adherence and the intervention was, I think, as good as any or better than any other study. And this is looking at low-fat versus high-fat diets. And there were major differences in these groups. And with a careful attention, and he emphasized healthy versions of both of these diets, there was essentially the same weight loss on either high-fat or low-fat diet, as long as it was healthy diets. And also, this, again, partly an intervention effect, but this is looking at 12 months. So it does seem that diet quality can make an important difference. Lots of evidence, overall diet quality, but the percentage of calories from fat doesn't seem to be important for weight control. You can have good, healthy versions of high and low-fat diets. You can even have very low carbohydrate diets that are plant-based or vegan and probably are pretty healthy diets. So this is a debate on this topic. If you want to hear this, I was a co-author. David Ludwig organized this, and this is in Science, a really sort of top-tier overall science journal. We were asked to have a consensus statement from people across the spectrum. So this included a low carbohydrate enthusiast, a low fat enthusiast, and I'm neutral on this, and David Ludwig. And we did come out to a consensus here that with a focus on nutrient quality, good health, and low chronic disease, risk can be achieved for many people on diets with a broad range of carbohydrate to fat ratios. So again, the percentage of fat does not vary, does not have a major impact overall, but the quality of the diet is really important. Now, how much can we reduce risk of major diseases by lifestyle, diet and lifestyle? We've done some analyses. This goes back 20 years now in the Nurses' Health Study, looking at a package of lifestyle factors. Of course, not smoke, keep body mass index less than 25, moderate exercise, and a good diet, and we created a little score there, and modest alcohol consumption, which was obviously optional. And we could see that if everybody in the population, based on data from 14 years of follow-up, if everybody had adopted that set of low dietary and lifestyle factors, it would have reduced heart disease risk by about 82%. So huge reduction is possible. But only 3% of the people in the Nurses' Health Study even were following that healthy lifestyle package. So huge potential for additional risk reduction. We did a similar kind of analysis for type 2 diabetes, and there we could estimate that over 90% of type 2 diabetes is preventable by diet and lifestyle. Yet we're in an epidemic of diabetes. So we actually know how to get out of this, but we're not following the path we need to go on, and clearly need to give much more attention to that. Now, what about compared to medicine? And the unfortunate situation is if most people go to their doctor, you're not going to hear much about dietary advice. In fact, not even asking about what we're eating to know where to begin. The one most direct comparison of medicine versus lifestyle was the Diabetes Prevention Project. And the top line is the control group, And then the middle red line there is metformin, and the bottom line is lifestyle. And you can see there was a significantly lower risk with metformin as time is going on in this study, but much lower risk, about 50% reduction with lifestyle intervention. This included diet and physical activity primarily. Now, there is clearly much potential for lifestyle is much greater than in this study. First of all, their intervention was really a bit off target. And also, again, not everybody followed the advice to eat well and exercise too. And the evidence is that could be almost zero increase if everybody adopted, if a group adopted the total package of diet and lifestyle. So I covered a lot very quickly here. This is just a 30,000 view overview of what we've seen to be the most important aspects of diet and health. And we have what we put together as an alternative to the Department of Agriculture, My Plate. This is from our department, our healthy eating plate. And I won't go into the details here, but it emphasizes not just grains, but whole grains, and not just protein, but primarily plant-based proteins, and avoiding processed meat, modest amounts, if you want it, of dairy and other forms of meat, and plenty of fruits and vegetables, healthy fats, and of course physical activity, and for beverages emphasizing water, tea, and coffee. Those are all healthy beverages. So a few words then to switch back to the environmental challenge that I was asked with a colleague, Dr. Rockström, from Stockholm, to chair a commission sponsored by The Lancet, a major medical journal in the UK, and funded by the Wellcome Trust, to look at the possible pathway to feeding what will be about 9.8 billion people in 2050 a diet that is healthy and sustainable. The standard response is we need to increase a lot of grain production because we'll have more people and they want to eat more meat, so that we have to, the answer is to produce a lot more grains. That's been the sort of agriculture industrial response to that. But it doesn't look like that would be the healthiest response. So this is a huge challenge. We're way off track in terms of diet quality. We're way off track in terms of environmental trends. And we're adding 2.5 more billion people. And so how do we do this? It's enough to make you sort of run in the other direction, perhaps. But we did say we would take on this challenge. So we went through 4 steps here. First of all, defining a healthy diet based on best available evidence from controlled feeding studies, like I've described, long-term epidemiologic studies, and randomized trials where we have them. And then there's another branch of science that's looked at planetary boundaries, really trying to define what is the limit of greenhouse gas that we can produce and be sustainable? What's the amount of water we can use and be sustainable? What's the amount of nitrogen fertilizer we can use and be sustainable? And so we defined those planetary boundaries with experts in that area. And then we looked at whether the healthy diet could fit in and enable us to feed 9.8 billion people and remain within the healthy boundaries. And I'll show you we can barely squeak by if we do everything right. And then we looked at strategies to get there, which I won't have time to cover today. But after reviewing a very extensive amount of literature, we set targets for different components of the diet here, which is a table with a lot of numbers. And I won't go into the details here, but we, on the basis of just health, we were just looking at health outcomes, we did set ranges. And for instance, for dairy, we said 0 to 2 servings a day, that you certainly don't have to have dairy, you can be healthy. And it looks like for up to 2 servings a day, you could be healthy. And for red meat, it came down to, the target was about 1 serving per week, about a hamburger per week, or 2 as a target and 2 as a upper limit, and so on. Or if you wanted to have big, juicy 12-ounce steaks, you could have that once a month if you really want to have those. And we went through the list. Again, I won't go into all of the details here. This is published in The Lancet, and it's available free online if you want to get a copy. It's about 60 pages of a lot of detail. So this is what the plate would look like. In some ways, not too different than my plate from a distance, but quite different when you look at what it really means. And it's lots of, on the left side by volume, roughly half fruits and vegetables, and grains being whole grains. This particular version, and there's flexibility, is about 35% of calories from fat, and the protein sources being primarily plant-based protein sources and moderate amount of healthy fats in there with very little sugar. So we went through lots of checks of nutrient adequacy. It's very consistent with a traditional Mediterranean diet, interestingly enough. That 35, the targets are basically about 43 grams of red meat plus poultry per day. The traditional Mediterranean diet was about 35 grams per day of red meat plus poultry. So it's very similar, but a lot of traditional diets in Africa, South America, Asia are quite compatible with these dietary targets. So this is looking at just focusing in on the implications for greenhouse gas emissions. And the food production boundary from the planetary boundaries people and the United Nations Committee on Climate Change basically allocates about 5 gigatons per year. Now that number is pretty hard to envision. It's so big for global production of greenhouse gases. And in 2010, our baseline data, that's just about where we are. We had just, the world was producing about 5.2, so just a little bit over the boundary. But you add in 2.5 billion people who, and the projections are they're eating more red meat. China's actually caught up to the United States now in red meat consumption, amazingly. And you go on to project out to 2050, which is our sort of goalpost that we were using. Could have said another year, but that's what we were using. If we continue on the present trends, we would be at about 9.8 gigatons per year of greenhouse gas from the food system. So about double the planetary boundary. So our path is leading us way off track. But if we just adopted the targets that I described, that would get us back to 5.0. So we'd be right at the planetary boundaries by adopting these dietary targets universally. And if we could get some further reduction by reductions in waste and some improvements in agricultural practices, but the big reduction is really coming from change in diet quality. Then we did a series of analyses using 3 different models to estimate what percentage of deaths that could be prevented if everybody adopted those dietary targets. And all 3 analyses came out to pretty similar numbers, but about 20 to 25% reduction in all causes of death around the world, which is a big number, and for several reasons that's almost certainly some underestimate as well. This is adult deaths. Well, those are a lot of numbers, a lot of analyses. What does this look like down on the ground? Well, this is actually our family farm in Michigan, up in the thumb of Michigan, Bad Axe, little town there, the farm was put up in the late 1800s. The barn was put up in the late 1800s, and this is our grandchild there. He's a cute little guy, actually getting a little bit bigger fast. And growing up, it was probably a sustainable system, that it had been like that for generations in the family. It was basically a small dairy farm, as one would find across the Midwest. But sadly, this is what it looks like now. And like the Midwest, the hedgerows have disappeared. It's just vast monoculture of corn, sometimes alternating with soy. This is our farm, the next farm, and the next farm, just all rolled up into one vast monoculture. And the sad thing is that this is not only destroying our environment, but of all the grain produced in the United States, only about 10% is actually eaten by humans. About 35% is for ethanol to fuel cars that are bigger than we need to be. About 45% is fed to animals. About 15% goes into what they call manufacturing, like high fructose corn syrup. And only 10% is eaten by humans. So how could we have produced a system that is so bad for the environment, so bad for human health? Now this is a little bit of a complicated figure, but I think it's worth understanding because this is from the UN IPCC group that is defined a pathway to get to 2100 and not go over 2.5 degrees centigrade increase in temperature. And so I'll just take a couple minutes here and describe what's going on, because it does show how the food system and our diets fit into this. That the different bands are different sources of greenhouse gas emissions. At the top is from energy production, pretty big, and then we have from manufacturing and transportation, which are really huge big sectors. And that orange line, sort of through the orange strip through the middle, that's from the food system. And that the goal is to get to zero net greenhouse gases. In other words, production reaching sequestering by 2039. And the goal point here is this is running out to 2050. So you can see that the orange line for food production, as I mentioned earlier, that's 5 gigatons per year. That essentially, it's inevitable that we will produce some greenhouse gases from food production. And I projected out that straight line across the top. That is where we go on the present path of the business as usual model, which ends up with about almost 10 gigaton year production compared to where we need to be. But by adopting the healthy dietary targets, we can get the food sector back to what it should be according to the UN pathway. So we can't get to the goal we overshoot the goal if we don't change our diets. But this also tells us we've got to, in fact, we're in the food area, we need to do our work, but these other sectors have to change in a very big way too. That projection of getting there is assuming that we're basically done with fossil fuels by 2050. We do have to leave that coal, that gas, and the petroleum in the ground, or else we will not come anywhere near achieving the goal. So I think that's an important point to keep in our minds. We need to do everything possible. Getting there, even with the healthy dietary targets, will not be possible unless we get fossil fuels out of our world economy, all our systems by 2050. So this is a huge, huge issue. The way we move about, how we heat our buildings, everything we do does need to be done with green energy, or we will not come close to meeting the goals. That green section at the bottom is also noteworthy because that's a big assumption. That's carbon sequestration. And actually, we don't really know how to do that quantitatively yet. And we're counting on a huge amount of that by 2050 of sequestering carbon. The best way to do it from what we know now is planting trees. And some agricultural systems can sequester some carbon, but we need a whole lot of research investment in that area because there seems to be a lot of variability, and many agricultural systems do not sequester carbon, even when they're producing healthy food in a way that is relatively sustainable. So that's the big map picture, I think, and it's worth trying to understand. Just to conclude, we are at a fork in the road. Our current path is fueling climate change and other environmental damage, and also the non-communicable disease epidemic. These environmental changes are damaging our resources for food production, so we're in sort of this vicious circle again. The climate change is also making it difficult to produce the food that 9.8 billion people will need. But the good news is that there is a double win path that can improve health and well-being for everyone. And this will require unprecedented changes in the foods that we eat and how we produce them. And achieving this will require the active engagement of every sector of our country, certainly everybody here. And just to end on the positive note, we do have a good weapon, if you might call it, on our side, and that is good, healthy food, which can be a double win in helping us achieve a sustainable environment, making everybody much healthier, and it can be really enjoyable at the same time if it's produced in a good way. So thank you. Stephen said we had a few minutes for questions. Is that right? Yes. I guess the microphone's back there.
Not on yet. Why are potatoes, assuming we'll exclude fried potatoes, not on your healthy eating plate? And let's take a purple or a sweet one. I'm just curious what went into that. A lot of people ask.
Right, yeah, good question. That in some ways they're a whole food, but of course they are very different than the potatoes that were given to us by the Incas. And we do see that they are a very big glycemic load. So if you compare them to whole grains, we see, as you'd expect by their high glycemic load, higher risk of type 2 diabetes. That doesn't mean that the potato consumption has to be zero, but not like in the Midwest, we had that white mountain on the plate almost once every day. That's not a good way to be eating.
Hello? I'm just trying to clarify. Are you saying basically that we could have a whole food plant-based diet in addition to a little bit of fish, a little bit of dairy if we so desire, nuts, seeds? That's basically the diet that you're advocating, and I'm just not sure about the oil.
Yeah, first of all, there were ranges, as I mentioned there, and the good thing is that there's a lot of variety in healthy diets. You can eat healthy in lots of different ways. That you can definitely have a healthy vegan diet. But I don't think I think there's no evidence when we get down into these areas of these different healthy diets that one is better than the other. So there's a lot of flexibility. And I think that's really important because we're not going to get everybody under one little tent. And so our ranges there are compatible with having a strictly vegan diet if you want it, but also diets that have a moderate amount of fish and poultry. And the fish, as I mentioned, you've got to get omega-3 fatty acids from someplace, and for a lot of people, that's going to be the best place to get it. And in terms of healthy oils, yes, when the Greeks, when you look at Crete back in the 1960s, where it had the lowest rates of coronary heart disease, they were getting 30% of their calories from olive oil. My Greek colleague says, yes, and that's why we also have the highest vegetable consumption in the world at that time, because it makes them attractive and enjoyable to eat. So there's a lot of flexibility in there, and that's a good thing. And as I mentioned, I think there's an interesting question whether you can have a very, there is a lot of interest, as you know, in people in paleo and very low carbohydrate diets. And I think it's important to recognize that a lot of people do get metabolically much better when they go to those diets because they are having problems with carbohydrate metabolism and can't handle the large amounts of carbohydrates, even the amounts that we might get from a lot of very large amounts of whole grain and some legumes. And so those people do get metabolic improvements, but you can also have, as someone pointed out yesterday too, you can have even a vegan, very low carbohydrate diet with lots of vegetables, nuts, seeds, healthy oils. And from all we can see, there's been no direct comparison, sort of a very low, all the comparisons of healthy low fat, healthy low carbohydrate look like they're about equal so far. But it's an area where we need some more research. But so far, the good news is that there's a lot of flexible ways to get to healthy, sustainable diets. And I think the bigger the tent, the better, because we need to get everybody in this tent.
Dr. Willett, thank you so much for your presentation. Just one question on your statistics about dairy and the reduced risk of fractures, which we all know and appreciate. One of the most common things that I hear when I'm coaching people to try to improve their diet, and we bring up the dairy conversation, they'll say, oh, I don't drink any dairy anymore at all. I just eat cheese. So, I mean, this is a rhetorical question, but I would love to hear from you, your position from the evidence. What could I respond to them in terms of their risks and the benefits of reduced risk fractures of cheese?
Yeah, in terms of fracture risk, it doesn't seem like there's any particular benefit or difference between getting the dairy in form of milk or cheese. For other health outcomes, also there's been some idea in some people's mind that cheese is much better than having milk. There was a study, very nice study done in Canada a couple years ago, actually sponsored by the dairy industry there, that compared cheese versus milk. And to their credit, they included olive oil and another unsaturated fat. And there was a very slight difference between cheese and milk in terms of effects on LDL. It's slightly favorable to cheese, but the really big bang was replacing either of those with the plant oils. So, and that's also consistent with a paper we published just a few weeks ago in British Medical Journal, looking at total mortality and cause-specific mortality, and cheese was related to higher risk, as you'd expect from these short-term feeding studies. So I think our targets, I didn't mention it, for dairy, I guess I mentioned the range was 0 to 2 servings of dairy a day, but I think it's, and we set the target at 1 serving a day, which would be, and actually preferably yogurt. There does seem to be some advantage to that. If we allowed, interestingly, we said, well, we did a bunch of sensitivity analysis, and what if everybody ate 2 servings of dairy a day? And we go way over the planetary boundaries there, that dairy production has a pretty big environmental footprint. So there's some role in some agricultural systems for some grazing, and if you can, the grazing should be primarily for dairy production rather than for beef production. So again, there's quite a bit of flexibility, but again, this 3 servings of dairy a day is really not justified, and we see that environmentally that would be highly unsustainable, and from a health standpoint, certainly not optimal.
Thank you, Doctor.
Yes.
What if someone don't have the time or don't enjoy preparing a lot of plant-based foods, and they just go to Whole Foods, go to the organic salad bar, which is already cut, diced, prepared, and brought home? And I heard something last night and today, that something called de-enzyming. I've never heard that before. And I'd like to know what you think about that as far as nutritional effect. And the second question is, like, do you recommend any kind of nutrition to help reverse, like most medical doctors said that arthritis, and like saying the spine is not reversible, but some people in alternative medicine it is. And maybe discs, spinal discs that are dried and compressed. I heard that also can be reversed, even though they're drinking a lot of water. And I also heard that something called oleation, which is actually entering oils into the body. So, what do you think that?
Yeah, well, I guess there's a lot of questions in your question about time and availability and cost, and all those things are big factors. And I think we need to find as many ways as possible to help people deal with those stresses, and it's particularly for lower income people have big. There's a very strong association, I'm sure you're aware, between income and diet quality, and we can trace that to differences in BMI and differences in diabetes and differences in premature death. Those dots can all be connected. So how do we make these healthy diets affordable, attainable, achievable in practice is something we need to work on. And almost wherever you are, there are things you can do to help make it easier. But we also need changes in policy. But in terms of like food services, a lot of food is eaten outside the home now, and we're working a lot with the Culinary Institute of America and major food services to have more healthy plant-based items on their menu available. There's a recent study that showed just making them more available without any education really substantially increases plant-based food choices. Not surprisingly, if you just got one on the menu, maybe somebody doesn't like some version, doesn't like that particular form of the plant-based diet. If you've got more choices and they're attractive choices, more people choose them. Whether it's in institutions, national policies that actually tip the balance away from the unhealthiest foods being the least expensive, to tip that the other way, so that healthy choices become the most affordable choices. There's lots of things, and that's in our Lancet report. I I'm not familiar with de-enzyming. I don't know what they're specifically meaning, but blanching foods basically is a way of killing enzymes, deactivating enzymes, so you can prepare foods in advance and they stay fresher. And that's been used for a long time. The arthritis issue is a very big issue. It's a very major part of disability in the United States, and it's astonishing how little research there has been on prevention of arthritis. We are doing some studies now, and I have had a doctoral student. I got to work on a project because we have lots of data on that in the Nurses' Health Study, and we just haven't had the resources to touch it. But we are starting to see some important findings there that can give us at least some inroads in prevention of arthritis. But it's an area where we absolutely need more research. I haven't seen any really compelling data yet that we can have a substantial impact by diet. But that doesn't mean it's not there. It's just been seriously understudied. Yes.
Hi. Two quick questions. Number one, when you look at the Predimed and Leon study, there is a great reduction in recurrent heart attacks if someone has coronary artery disease. And so we say oil's safe, but that really hasn't been compared to no oil whatsoever or low oil. In other words, if we look at Ornish's randomized controlled trials or Esselstyn's anecdotal studies, they get far better results than even Predimed and Leon. And so is it safe to say oils are okay for us if that really hasn't been studied? And secondly, back to potatoes. Glycemic index is really interesting to me because determining a glycemic index in someone with a bunch of intracellular fat eating, animal meat and things like we've already looked at that increases the risk of diabetes, and saying that this potato increases their glycemic index, that's true. But if someone's on a whole food plant-based diet with very low oils and therefore very low saturated fat, therefore very low intracellular fat, they can handle a potato without any problem. And it is probably the most satiating food, so vital part of the diets that I prescribe for patients.
Yeah, there's really been no randomized trial that's been done with high oil or low oil. You're right. Although in some ways, actually, there were in the Leon Heart study, that was a secondary prevention study, not Predimed. But there was a 70% reduction in risk of recurrent heart disease with, again, we can't attribute that benefit to one single item, oil or anything else, because it was part of a whole Mediterranean diet package. But it did, it was, the primary intervention was healthier fats, probably not even optimally healthy fats, because it was in a form of a margarine that did have a little bit of trans fat in it. But there has not been a head-to-head comparison, you're right, of a very low-fat diet with a diet that would have higher fat but healthy fats. And part of it is that it's been really hard to keep people on those low-fat diets. Now, as in a secondary prevention trial, it does seem like there's more opportunity there because people are sort of just one foot in the grave and pretty high motivation there. So it would be nice to have such a study. We don't have that now, but what we can see for effects on lipids and risk factors, they are better replacing some of that carbohydrate with some healthy fats. And that's about the extent of the literature that we have. Now, with the issue of potatoes, if you have somebody who has really low insulin resistance, they're lean and they're active, then we can tolerate potatoes much better. But if you take the average American, they cannot tolerate them very well. So I think if we're talking to the general public, it looks like there's a problem. Being lean and active makes us, we have much lower insulin resistance and we can definitely tolerate more carbohydrate. But as I mentioned, it is a doubly serious issue globally because it does, I could talk for about 10 minutes or so on this, but in Europe, it looks like people who are more resistant got selected out over the last few hundred years, not entirely, so that diabetes risk is lower. But even in the Nurses' Health Study, the European women had the lower, everything else controlled, much lower rates of type 2 diabetes. Asian women, Hispanic women had 2 to 3 times the risk of diabetes, everything else controlled. And it does, more careful studies have shown that there's much less tolerance for higher carbohydrate intake in minority populations, which are really the majority populations globally. As I mentioned briefly, if everybody has a really healthy diet, then diabetes risk will be low. But increasingly, the rest of the world has become much more sedentary, which if I could turn a dial and change that, I would, but that's a reality, and can tolerate carbohydrates much less well than they did before. So we do have to be careful. This is one area where it does seem like there are some, depending on people's origins, different rates of, different prevalences of insulin resistance. And what we see happening, like in India, the rates of diabetes are in urban populations now, according to my colleagues who have done a recent survey, they're up at around 50%. And actually that was true. The very first study I did as a medical student was a survey of Native American population in the Upper Peninsula of Michigan. And there we found rates of diabetes that were 4 times higher than in the general American population. And that's what seems to be happening worldwide now. So we do have to be very careful about higher carbohydrate diets in that kind of context. And especially, your point is well taken too, these higher carbohydrate diets could be tolerated while everybody is very lean and active and having less refined carbohydrates, but that picture has changed. There's television everywhere. People are riding around instead of walking and bicycling, and that all converges to be part of a perfect storm of many factors that are coming together to create this global epidemic of diabetes that's happening right in front of our eyes. It's what we saw in the Indian reservation in northern Michigan almost 60 years ago now, and it's happening on a global scale at this moment.
Number one, I wanted to thank you for your work with the Culinary Institute and wonder how you are working with the students, because I find if we go to restaurants, sometimes it's really hard to find a good vegan option. So I was wondering exactly how you're implementing it. And two, I was wondering if you're familiar, Jack Kittredge from NOFA, Northeast Organic Farmers Association, has written a white paper on carbon sequestration through regenerative farming. The Bionutrient Food Association is doing no-till cover crops and talking about carbon sequestration. And Eric Tansmeyer has a book on that topic also.
Yeah, well, with the Culinary Institute, that we sort of have some joint mini courses we're putting on. And basically, our group from our department teaches the nutrition part, and the Culinary Institute, which hopefully motivates people and it gives them the rationale for improving what they're offering. And the Culinary Institute then sort of shows how to put that together in terms of real meals and menus. And that's been really good. That allowed us to get trans fat out of the food supply much earlier, because before those joint programs, the food service people had not even heard of trans fat, much less understand what it was doing. And so they spent a lot of effort then essentially taste testing, reformulating menus. So when the ban came, they were prepared. And that worked also without getting more whole grain options on the menus. And we have been, over the recent years, having more plant-based options on the menus too. So I was just out at the retreat a couple weeks ago and had some sessions on creating healthy plant-based veggie burgers. There's, as you all know, sort of Impossible Burger and Beyond Beef Burger are out there, but those are not the healthiest options. There's a lot of room for creating, there's a whole lot of horrible veggie burgers out there too. What we want are good veggie burgers that people enjoy and want to eat, that are aspirational, because they know it's good for planet, good for their health, and it tastes good. We have to hit all three of those. So that's basically what we're doing. And yes, there's a lot of interest, as you said, in regenerative agriculture. but we need a lot more investment. In our Eat Lancet report, we had some experts in that area on the report, and so far the literature, from their view, I'm not an expert in this, is that there's a lot of variability in terms of how much carbon can be sequestered that way. So we need to understand how best to do it, where to do it, and there's not a universal simple solution, it seems, in that area. But it's really good that we need more people working on this to understand how to do it as well as we can, because that big green section there on that pathway does assume that we are going to sequester a lot of carbon, and doing it through food systems is almost for sure going to be the best way to do that. So any additional efforts in working on this and documenting and studying what works and what doesn't work under different conditions, that area is in great need of much more investment.
Dr. Willett, this week the media has been doing reports on increase in life expectancy. They've been saying that it's partially due to the decreased deaths in opiate overdoses and decreased rates of death by cancer. But all the information that we've been receiving so far at the conference has stated that the death rates have leveled off. Are you aware of what's being reported on right now?
Yeah, I haven't seen the details of that new report. So we have made some progress in the opiate control area, and that will definitely help. But it's not going to, and we should put even more efforts in there. So it's possible that we can see some little recovery from this 3 years in a row decline. But the underlying trends are very worrisome here, that even before the epidemic was occurring, the opioid epidemic was occurring, we were leveling off in other countries like Japan, we're charging ahead. So yeah, we'll need to keep an eye on these data, and hopefully we will have reduced some of that contribution to the opioid epidemic. But we've got to deal with these longer term trends as well. Great, well, thank you.